You guys, welcome to my channel. Today we are doing the cardiology section and revising the Mrcp notes for the upcoming Mrcp exam. So let's dive right into it. We are doing the infective endocarditis right now. So let's begin. Infective endocarditis, the strongest risk factor for developing infective endocarditis, is the previous episode of endocarditis. The following types of patient affected: a normal wall, more than 50%, typically acute presentation; rheumatic heart disease; prosthetic wall; congenital heart defects; intravenous drug use; IVDs, example, typically causing tricuspid lesions. So if you had a normal heart, a prosthetic, rheumatic, and a congenital and IV drug users. Now the causes you have to remember is Streptococcus viridans is the most common cause. Viridans, this word you have to remember, viridans. Staphylococcus aureus is a coagulase positive, especially acute presentation in intravenous drug users. This is a gram positive in intravenous drug users when they are putting on a needle. The skin bacteria, that is Staph aureus, goes into the IV. Goes through the IV into the body. That's why Staph aureus in intravenous drug use. Staph epidermidis recons coagulase negative, especially prosthetic valves. Streptococcus bovis associated with colorectal carcinoma bovis is bovil. Streptococcus mitis, viridans streptococcus, following dental work. M for mouth, M for dental work. Non-infective like SLE, Liebman's Sachs, malignancy, Marantic, and non-bacterial thrombotic endocarditis. Now culture negative causes include, if you had a prior antibiotic therapy, Brucella, Bartonella, Coxiella burnetii, Brucella, Bartonella, Coxiella burnetii in Hackett, Haemophilus, Actinophilus, Cardiobacterium, Eikenella, Kingiella. Following prosthetic valve surgery, Staphylococcus epidermidis is the most common organism in the first 2 months and is usually the result of perioperative contamination. Then epidermidis means because perioperative contamination has been there. So prosthetic valve surgery he has had, and then Staphylococcus epidermidis got into the body. After 2 months, the spectrum of organisms which cause endocarditis returned to normal, except a slight increase in Staph aureus infection. The most common endocarditis, Streptococcus viridans, step epidermidis, if less than 2 months of post-valve surgery. Example: a patient with sigmoid adenocarcinoma, fever, shortness of breath, echo showing infective endocarditis, Staph bovis. Sigmoid adenocarcinoma, carcinoma colon of the bowel. Coxiella infection widespread in domestic and farm animals. Ox, farm animals, is usually spreads between animals' buttocks, which acts as reservoirs of infection. Infection will be spread by unpasteurized milk. Coxiella is usually diagnosed with complement fixation. Complement fixation, and treatment is doxycycline. The dangerous complication of aortic valve endocarditis, that it can cause aortic root abscess, which can cause damage and erosion of the AV node, resulting in prolongation of PR interval and 12-lead ECG. So ECG should be performed daily to monitor the infections involving the aortic root or aortic valve. And if infective endocarditis is, we have to see the modified Duke criteria. Infective endocarditis diagnostic pathological criteria positive, or 2 major criteria, or 1 major, 3 minor criteria. 2 major, or 1 major, 3 minor criteria, or 5 minor criteria. Pathological criteria: positively histology, positive microbiology, pathological material obtained at the autopsy or cardiac surgery, valve tissue, vegetation, embolic fragment of endocardial abscess content. This is the pathological criteria. Now major criteria include positive blood culture. It should be at least 3 sets of blood culture samples from 3 different sites. They are positive in 75% of cases of bacterial endocarditis. Because bacteria may be periodic, blood culture should not be taken simultaneously, but should be taken sequentially from 3 different sites 1 hour apart. 1 hour apart. Draw 3 samples of blood from 3 different sites, with the first separated from the last by at least 1 hour over 24 hours. First separated from the last. Okay, 2 positive blood culture showing typical organism consistent infective endocarditis, such as Streptococcus viridans and the Hackett group. Persistent bacterium from 2 blood culture taken more than 12 hours apart, or 3 or more positive blood culture with the pathogen less specific, such as Staph aureus, Staph epidermidis. 2 blood cultures, if we are taking 2 blood culture, it should be 12 hours apart, or 3 if we are taking, then it should be within 1 hour apart. Positive serology. Serology is done for Coxiella, Bartonella, Chlamydia, psittaci, or positive molecular assays of specific gene target. Evidence of endocardial involvement, positive echocardiogram, oscillating structures, slitting structures, abscess formation, new valvular regurgitation, dehiscence of prosthetic wall. It is important to remember that a normal echocardiogram does not exclude infective endocarditis. But now, what is the minor criteria? Predisposing heart condition or IV drug use. Microbiological evidence does not mean major criteria. If there is a fever, vascular phenomenon like major emboli, splenomegaly, clubbing, splinter hemorrhage, petechiae, purpura, immunological phenomena like glomerulonephritis, Osler's node, Roth nodes, and Janaway lesions. This is vascular, this is immunological. Then poor prognosis: Staphylococcus infection, acute endocarditis, poor IV drug use, often left and right sided disease, infection of the aortic rather than the mitral valve, prosthetic valve endocarditis, especially early acquired during surgery, culture negative endocarditis, low complement level, old age. In IDDM is I think IDDM is diabetes mellitus, severe comorbidities. Other factors that are crucial in prognosis assessment of the endocarditis, which is fungus or gram-negative bacilli. Endocarditis complications include heart failure, renal failure, stroke, septic shock, and periannular complications. And echocardiogram finding includes severe left-sided valve regurgitation, low EF, pulmonary hypertension, large agitation, and severe prosthetic valve dysfunction. Infective endocarditis, streptococcal infection, subacute bacterial endocarditis, Streptococcus viridans carries a good prognosis. Mortality according to staff is 30%, then bovine organism 15%, and strep is 5%. Current antibiotic is by initial blind therapy. Give amoxicillin. Consider adding low dose gentamicin. Amoxicillin and gentamicin. Penicillin allergic or MRSA severe sepsis, give vancomycin, low dose gentamicin. Amoxicillin, gentamicin, here also low dose gentamicin and vancomycin. If it is penicillin allergic, because amoxicillin is a penicillin and in place of amoxicillin they are giving vancomycin. If prosthetic valve, vancomycin, rifampicin, low dose gentamicin. Prosthetic valve is vancomycin plus rifampicin. Native valve endocarditis caused by staphylococci, vancomycin and gentamicin. If first one is flucloxacillin and gentamicin. In place of flucloxacillin, here they are giving vancomycin. Prosthetic valve endocarditis caused by staphylococci. This is a native valve, this is a prosthetic valve. For prosthetic valve, this R is this R. Otherwise, it's same from above. If penicillin allergic, the vancomycin, low dose gentamicin, we give rifampicin extra. Endocarditis caused by fully sensitive streptococcus, then give benzyl penicillin. If it's allergic to penicillin, then give vancomycin and low dose gentamicin. Endocarditis caused by less sensitive streptococci, then also less sensitive, then you have to give gentamicin here and here also. The most useful lab test for monitoring response to infective treatment, which is usually obvious clinically, serial CRP estimation. This is of much more use than the ASR, which is much slower to fall. Infective endocarditis caused by Candida albicans or bicuspid aortic valve in IV drug user is aortic valve replacement followed by amphotericin B. Amphotericin B IV for 6 weeks, like 1.5 months. You have to keep on giving amphotericin B, which is a pretty long time. The IV drug IVDA or MRSA is a causative organism in about 60% to 70% of the cases, with hematogenous spread of bacteria resulting in frontal lobe abscess. If it is a MRSA, it goes to frontal lobe, and if you give IV flucloxacillin and gentamicin combination, which is a result of culture. If MRSA is confirmed, then you have to give vancomycin and gentamicin. Teicoplanin has a similar spectrum of antimicrobial activity to vancomycin, but has slightly more anti-streptococcal activity than vancomycin, slightly less anti-staphylococcal activity. It is not a first-line agent in the treatment of endocarditis. Example: a young male with RTN or if of the left tibia and fibula, then after 1 week develop fever, tachycardia, low BP, splinter hemorrhage of fingernails, systolic murmur, rise serum creatinine and urine. Urine is showing blood plus protein plus leukocytes. Then infective endocarditis due to staph due to extensive trauma. Initial blind treatment before results of blood clot, that is IV flucloxacillin plus IV gentamicin. Indication for surgery: when will you do a surgery for infective endocarditis? Severe valvular incompetence, severe mitral regurgitation causing refractory pulmonary edema, severe mitral regurgitation with signs of pulmonary hypertension, cardiac failure as a result of valve destruction refractory to standard medical treatment. Aortic abscess often indicated by lengthening PR interval. Infection resistant to antibiotics such as fungal infection of multi-resistant organisms like Brucella, Klebsiella, Pseudomonas aeruginosa, vancomycin resistant enterococci. Persistent bacterium may despite appropriate antibiotic therapy. Extension infection to extravalvular sites. Recurrent emboli after antibiotic therapy. Early prosthetic wall endocarditis. Dehiscence obstruction of the prosthetic wall. Persistent fever for 10 days. In culture negative prosthetic wall endocarditis. So mostly the causes, the reasons which we will do surgery in infective endocarditis is usually if the valve has become involved, like this mitral ligation. If there is a cardiac failure, then aortic abscess has been there. Then the infection itself is infection resistant, persistent, extension, causing emboli after therapy, or prosthetic valve is there within 2 months, a dehiscence of prosthetic valve, a persistent fever for 10 days. So any complication arising out of infective endocarditis, you have to start the surgical treatment of it. Valve surgery may be deferred until the patient is upper unless there is a hemodynamic compromise, large vegetation are seen or abscess is present. The ESC makes the following recommendation with regard to infective endocarditis related to cardiac devices. Prolonged antibiotic therapy and device removal are recommended. Percutaneous extraction is recommended in most patients with cardiac devices, even those with large vegetation like 10 mm. After device extraction, reassessment of the need of reimplantation is recommended. Routine antibiotic prophylaxis recommended before device implantation. Infective endocarditis prophylaxis. The 2008 NICE guideline fundamentally changed the approach to infective endocarditis prophylaxis. What it's not yet clear if there are any circumstances in which NICE would recommend using antibiotic prophylaxis. The 2008 guideline from NICE have radically changed the list of procedures for which antibiotic prophylaxis is recommended. It recommends that following procedure do not require prophylaxis, like a dental procedure, GI tract procedure, GUT tract procedure. This includes urological, gynecological, obstetrical procedure, childbirth, upper lower tract, respiratory tract. This include ear, nose, throat procedure, and bronchoscopy. So all these procedures, they don't need infective endocarditis prophylaxis. They, however, do suggest that any episodes of infection, any episodes of infection, people at risk of infective endocarditis should be investigated and treated promptly to reduce the risk of endocarditis developing. A person at risk of infective endocarditis receiving antimicrobial therapy because they are undergoing a gastrointestinal genitourinary procedure at a site where there is suspected infection. They should be given an antibiotic that covers the organism that cause infective endocarditis. According to NICE guidelines, antibiotic prophylaxis against infective endocarditis is not recommended in common cardiac valve abnormalities. Prophylaxis is only recommended in those patients who are at highest risk of adverse outcomes in the development of endocarditis. These patient groups include, so prophylaxis should be given to these patients, like if he had a previous endocarditis, acquired valvular heart disease, stenosis, HOCM, prosthetic cardiac valve, prosthetic material used for cardiac valve repair, unrepaired congenital cyanotic heart diseases including palliative shunts and conduits, completely repaired congenital heart defects with prosthetic material or device whether replaced by surgery or by catheter intervention during the first 6 months after procedure, repaired congenital heart disease with residual defects, persistent leaks or abnormal flow at the site or adjacent to the site of a prosthetic patch or prosthetic device which inhibit endothelialization. Cardiac transplantation recipients who develop cardiac valve abnormalities. So if he has a congenital thing, this should have a prophylaxis, and transplantation should have a prophylaxis, or he has had a previous endocarditis and a valvular lesion. The congenital heart diseases are types, like a cyanotic is mostly VSD is most common, like account for 30%, ASD 10%, PDN coarctation of aorta. VSDs are more common than ASD. Of an adult patient, ASDs are more common. New diagnosis generally presents later. Cyanotic is the tetralogy phallic transposition of great arteries, tracted with atresia, not mitral atresia, pulmonary valve stenosis. Total anomalous pulmonary venous connection consists of abnormality blood flow in which all four pulmonary veins drain into systemic veins of the right atrium with or without pulmonary venous obstruction, that is systemic or pulmonary venous blood mix in the RA. So T times 4 and P. Sorry about that. Then phallot is the most common, more common than the TGA, transposition of great arteries. However, TGA is more common lesion in patients with phallot, generally presenting around 1 to 2 months following the identification of murmur-cyanosis. TGA is most common presenting cause of cyanotic congenital heart disease. Congenital heart disease. VSD is most common, TGA most common childbirth. Phallot is most common overall. At birth, TGA. Note: aortic regurgitation may feature of osteogenesis imperfecta. The major cause of neonates with complete heart block, neonatal lupus, may be caused by autoimmune disease, particularly anti-Ro antibodies in the mother who has SLE during pregnancy. The left ventricular hyperplasia occurs when left ventricular chambers fail to develop and blood into systemic circulation from the right ventricle via the pulmonary artery and patent ductus arteriosus. PDA. Overview is a cyanotic congenital heart disease, connection between pulmonary trunk and descending aorta. More common in premature babies born at high altitude or maternal rubella. Ruby shows PDA. Infection first trimester. What they present with left subclavicular thrill, continuous machinery murmur, but when the shunt reverses, as in patient with large PDA or with pulmonary disease, the murmur becomes softer and shorter. Large volume bounding collapsing pulse, wide pulse pressure, heaving apex. Management is indomethacin closes the connection between the majority of cases if associated with another congenital heart defect and amenable to surgery. Then prostaglandin E1 is useful to keep the duct open until after surgical repair. VSD is the most common cause of congenital cyanotic heart disease. They close spontaneously in about 50% of the case. Non-congenital causes include post-myocardial infarction. Features classically pan-systolic murmur, VSD pan, which is louder and smaller defects. Complications include right heart failure, Eisenmenger complex, infective endocarditis, aortic regurgitation due to poorly supported right coronary cuff, surrounding aortic collapse. ASD, often diagnosed in adulthood and represents 30% of all adult congenital heart disease. Females to male ratio is 3:1. 75% are ostium secundum, because this S shows S secundum. Communication at the level of the atria allows left to right shunting of blood, leading to considerable increase in right heart cardiac output, leading to pulmonary hypertension. Fixed splitting of S2 and auscultation and mild systolic murmur, OP area, ECG showing RBBB and right axis deviation. Patient often present with AF, chest tissue pulmonary plethora. Significant ASD should be repaired below the age of 10 years or as soon as possible if diagnosed at other low. TEE can give sufficient anatomical data about the site and site of the defect. It is well worth that the patient undergoing EP study prior to any closure procedure. Any abnormal pathway predisposing to atrial flutter fibrillation should be considered for RFA ablation, which can be curative. Atrial fibrillation associated more with atrial septal defects. In the presence of Eisenmenger syndrome, the maternal mortality rate is approximately 40%. Pregnancy is contraindicated. With older maternal age, increasing the risk of pulmonary hypertension and Eisenmenger. In the absence of any structural heart disease, Eisenmenger, the pregnant woman with ASD, and no significant increase or risk compared to the general population. This is Luthenbacher syndrome, MS plus ASD plus minus AF. Luthenbacher. This is first described in 1916 by Luthenbacher and a syndrome characterized by both mitral stenosis and ASD. Both conditions may be congenital, occur concurrently, or the mitral stenosis may occur as a result of rheumatic fever or other. Constituents of Luthenbacher syndrome is high in women due to high incidence of congenital ASD, cardiac and the mixed due to the two concurrent lesion. Presentation typically late in life with fatigue or atrial fibrillation. Ideally, surgery should be performed as early as possible to reduce the risk of Eisenmenger syndrome in untreated patient. ASD defect may have up to 30% of congenital heart disease detected in the adult population. The female to male ratio is 2:1. 30% of ostia secunda. They are commonly present during pregnancy with either breathlessness or palpitation. They usually no audible murmur with ASD. The combination of right band and branch blocks and right sexual dictation on the ECG may cause in secondary. More likely, the patient should have had urgent echocardiographic assessment to assess the state of right heart and followed up very closely. The prognosis is very poor if they develop Eisenmenger syndrome. Early surgical intervention of the birth of child consideration. Pregnant female with palpitation incomplete RVB fixed bleeding splitting ostium secondum ASD urgent echo and urgent surgical intervention after the delivery. PFO is present around 30%, 20% of the population like us. It may allow embolus from DVT to pass from right side of the heart to the left side leading to stroke, a paradoxical embolus, while ASD may allow embolus to pass from right side of the heart to the left, but most common cause is PFO. There is also appears to be an association between migraines and PFO. Some studies have reported improvement in migraine symptoms following closure of the PFO. Transesophageal is the investigation of choice to investigate PFO, although transthoracic echocardiographic contrast may be alternative. Paradoxical embolization from right-sided thrombus DVT is going to the left-sided embolus. Example, stroke is must obviously pass from the right to left side of the heart. The following cardiac lesion may cause events. PFO present in around 20% of population. ASD much less common. PFO and ASD. Excuse me. TEG provides superior views of atrial septum, therefore prefer transthoracic echocardiography detecting patent foramen well. Okay, thank you guys.